All right, this is healthcare reform in our series number 10, and we're going to just to cover a couple things from earlier in May, and then we'll go into new taxes and revenues for under the Affordable Care Act. This is Medicare Part D, and Medicare Part D was part of the Medicare Modernization Act. That's kind of the short version of the name of the law. That was passed in 2004 under the Bush administration. One of the things that was kind of strange about that, when you think about it, is there was this thing called the donut hole. And for those people that are on Medicare, there would be basically a benefit under Medicare for the first several amount of dollars. I'm using that term because it changed every year since then. And then there would be a point where there would be called the donut hole. And the donut hole would be where there was no coverage under Medicare, and that was an additional part of money. And then once you had incurred expenses over a certain amount, then all of a sudden Medicare would start paying again. So it paid for the a portion of the first part of of a Medicare beneficiary's prescription drug expenses, and then it stopped paying entirely. And then, if you had just a tremendous amount of prescription drugs, it started paying again. Kind of a weird way to do it, and it was very difficult to communicate to employees who are on Medicare that this would apply to. One of the things that healthcare reform has done, and which we're going over at this point, is it's trying to close the donut hole. Close the donut hole. The problem with Medicare Part D is it really was an unfunded mandate. So when we talk about government debt and we talk about health care, these two go together because actually pharmaceuticals are the single biggest category of cost in health care. It's kind of a strong statement, but it's true. Roughly 1998, up until that point, surgery was really the modality by which people would get better. They would cut out or fix something by cutting you open surgically. And then as pharmaceuticals became more advanced, and all you have to do is watch television today to know this, pharmaceuticals replaced, in terms of the single largest cost item for all of healthcare, not just Medicare, all of healthcare. Pharmaceuticals are less invasive. Well, they are primarily non-invasive. And as a cost, they now greatly surpass surgery. And there is a portion of the healthcare pie. They are by far the single largest healthcare cost for you and I, for Medicare people, for everybody. So Medicare Part D is indeed a very, very expensive item. Now, the annual deductible, some of this stuff is pretty elementary, but we just don't want to leave anything up for assumption. The annual deductible that a person who is on Medicare Part D, now this could be somebody who is retired, is not working anymore, or as it applies particularly to probably you folks, as an employer, if you have somebody who is entitled to Medicare and they select Medicare Part D, then you pay for that, and the deductible, in other words, the first $325 of prescription drug expense that a Medicare Part D beneficiary would incur in 2013, that's the deductible. That's what they got to pay for. After $325, then you enter the first part of what Medicare pays. Now, allow me to go a little bit deeper here on Medicare entitlement, because this is something that as an employer, as an HR person, as a benefit person, as an owner of a company, whatever role you may play, there's a couple things that I have found a lot of people don't understand. A person who turns 65 is eligible. That's the operative term. They're eligible for Medicare, but they are not merely because they turn age 65 entitled to Medicare. Eligible, but not entitled. So you can have somebody that works for you who is 65, 66, or whatever, older than 65, and that doesn't mean that they're entitled to Medicare. It means they're eligible. The only way that a person can become entitled to Medicare, now I'm not talking about people that are on disability, that sort of thing. I'm talking about employees now. The only way that somebody can become entitled to Medicare, one of your employees who's in that age range, is if they first sign up for Social Security. Okay, so when you sign up for Social Security, which you can start doing that at age 62, that doesn't mean you have to take the benefits, but you do have to sign up for it so that when you turn 65, you will move from eligible based on age 65 to entitlement only if you also have signed up for Social Security. So if one of your employees is 65 and they want to get Medicare and go through the Medicare secondary payer rules and that sort of thing, having your health plan pay part of it and having Medicare pick up the rest of the tab, well, Medicare will not do that because they will only become entitled if they are first signed up for Social Security benefits. Okay, now we got that rule out of the way, but a lot of people don't know that. So anyway, the deductible for 2013, $325. Now, a person who's on Medicare Part D, starting in 2014, the annual deductible will probably go up, but currently we don't know what that number is. So we're going to use the 2013 number. So between $325 and $3,970, that's the donut hole. That's the donut hole. I beg your pardon. I misspoke. Please let me rephrase that. That's the first part of it, and then the donut hole begins after $3,970. So once you've satisfied, a beneficiary has satisfied the $325 deductible, then there's coinsurance that Medicare will pay part of that up to expenses through $3,970. For example, as it says here, an individual who incurs prescription drug costs in this corridor from $325 to $3,970 will pay only 25% of the costs. Medicare Part D, or in this case, the Affordable Care Act, Obamacare, health care reform, whatever you want to call it, will pay the additional 75%, as it says right here. Now that's good news for people that are entitled to Medicare and who select Medicare Part D. As an employer, that's a good deal because it's not money that's really directly coming out of your pocket or out of your ledger, but nevertheless it is an expense of the government, and obviously that's being funded by taxes. Okay, now let's talk about this donut hole concept here. Now the donut hole in 2013, because we don't know exactly what the numbers, they haven't released the numbers for 2014 yet, so we're just going to have to use these numbers, and the concept here is really the most important part. The donut hole for 2013 is any expenses that a Medicare Part D beneficiary incurs between $2,970, actually $271, through $4,750 this year. Now again, that number is probably going to change in 2014. But this range, between $325, $3,970, beneficiary pays 25%, Medicare picks up the rest. Between $20,971 and $4,750, Medicare pays nothing. That's the donut hole. Now most people, the thinking behind this is that most people are not going to have prescription drug costs that exceed $3,970. Now we can debate that because we all know that there's a lot of people that are on some pretty expensive medications. You can blow through that pretty quickly. Nevertheless, we're just going through the rules. I didn't make them up, neither did you. So that's the donut hole currently in 2013. No benefits through Medicare for RX costs between 2,971, anyway, 2,971 and 4,750. Now, if somebody really has a lot of prescription drug costs, and those costs run over 4,750, then it falls into the second level of Medicare Part D, and that's called the catastrophic coverage. So what that means is that a person who has just taken a lot of medications and they've incurred $4,750 or more, then that individual is deemed to have incurred catastrophic costs. Now that person or persons at an individual level will only have to pay 5% of the costs. So the first bunch of dollars, 25% of the costs is what the employee pays, or the person on Medicare Part D, which may be one and the same. Once they go through the donut hole where there is no cost and they're paying 100%, then all of a sudden they're considered a catastrophic individual. And at that point, from 4,750 and anything going forward, Medicare pays 95% of the cost. The employee, the Medicare Part D beneficiary, one and the same, whatever, pays 5%. Okay, so we've pretty much beat that one to a pulp. Now, the idea here is to close the donut hole. Medicare, we've already talked about kind of how this all came into being and how maybe it wasn't such a great engineered benefit by the government because this donut hole thing has caused a lot of consternation among people. So you can read this at your leisure here. It just kind of explains what I've already talked about, and really not much more than that. Now, the Affordable Care Act closes the donut hole by adding Part D cost sharing at every level of cost except the deductible, $325. Now, remember, I just got done saying that between, let's just go back there real quick, between 2,970, by the way, I believe that's supposed to be 3,970. I believe that's a typo there. And 4,750, the donut hole, there is no coverage currently. That will change January 1 of 2014. And what will change is that we're going to go from no coinsurance to at least some coinsurance for your employees who are also entitled to Medicare and they take Part D rather than your prescription drug plan if you offer a prescription drug plan. Now, how that's going to work, let's just read this together. Any individual who was enrolled in Medicare Part D plan as of the last day of a calendar quarter in 2010, all right, so there's a look-back period. Somebody who turned 65, like say today, would not be eligible for the rest of the stuff we're going to be talking about here as of 2014. I know this is complicated. I didn't make the rules, though. But somebody who turned, who was enrolled in Medicare Part D, meaning they were part of, they were 65, as of the last day of the calendar quarter in 2010, and who incurred costs covered by Part D in excess of the initial coverage limit, which at that point for 2010 was $2,850. That person then would be entitled to receive a rebate of $250 no later than the 15th calendar day of the third month following the end of the quarter. Now that happened last year for the first time. So people started in, I believe it was August, started actually getting $250 checks. So that part is already begun. Okay, that's happening, and that will continue to happen unless somebody changes the rules. Now, 2011 and beyond. After 2010, again, we're 3 years beyond that already, the Affordable Care Act created the Medicare Coverage Gap Discount Program. And this is the part that, on a going forward basis, all of those on the call here, or anybody that's hearing the recording of this, are going to want to know. And what that provides is that eligible folks with access to manufacturers' discounts for certain brand name drugs, the cost of which would fall into the donut hole. In general, the manufacturer's discount is equal to 50% of the negotiated price. In addition, the Act modifies the definition of qualified prescription drug coverage in a standard Medicare D plan to include coverage for generic and certain other non-generic drugs in the donut hole. However, individuals who are already receiving income-related subsidies or reduction in premium subsidies under Medicare Part D are not eligible for the donut hole coverage. All right, I wanted to read that rule, and I don't think anybody can read that and not be scratching their head. So let me explain to what that's talking about. Number one, the law is going to address the actual cost, the cost side of what drugs are purchased by either a PBM, a prescription drug manager, by Medicare, or well, that's pretty much it today in most instances. That's how pharmaceuticals are delivered, either through the government or through a PBM. If you have a private sector plan, which I'm sure all of you do, if you have a drug card, it's really, there's a prescription benefit manager that's running that behind the scenes, a PBM. Now, the cost that the government pays, since we're talking about a government program here, healthcare reform, the cost, the law mandates that the manufacturer give a deeper discount. So they're going to, people whine about the cost, and for good reason, of the cost of pharmaceuticals in the United States, the first part of what we just said here is going to address the cost of that. Now, that is not going to affect us immediately, but it's good to know that somebody is going to get, we're going to reduce the cost of drugs to the government. The second part of what this paragraph is talking about, we're going to go into this in the next slide more in depth, is that in the donut hole, whereas currently there is no, it's 100% paid for by the plan participant. This is also saying that the donut hole is now going to start having coinsurance, so that at all levels there will be some part that the Affordable Care Act will pay for medications, prescriptions that either are in the first part, the donut hole, or the catastrophic part of Medicare Part D. Hopefully that makes sense. If it doesn't, let's keep on going here. Now for generics, we all know that in a formulary, the generic drugs usually have the cheapest copay. So for generic drugs, an individual that's enrolled in a standard Medicare Part D plan has a generic gap coinsurance requirement for annual prescription drug costs incurred in the donut hole. Now, in 2011, that's 93%, which means that the donut hole, now with healthcare reform, which was passed, keep in mind, on March 22nd of 2010, beginning in 2011, 2 years ago, the donut hole started to provide some benefit to plan participants, Medicare beneficiaries of Part D. That benefit in the donut hole, again, before 2011, was zero. Now the benefit is the plan participant has to pay 93%. The benefit from Medicare is 7%. Nothing to write home about, but at least it is something. Now, that applies to generics only. The generic gap coinsurance is reduced by 7 percentage points each year through 2019. So there's like an index going on now. So now we're 2011, 2012, 2013, and soon 2014. Now, by 2020, keep in mind that it's going to be reduced. The cost in the donut hole will go down by 7 percentage points every year through into 2020. By the time we reach 2020, and I know that seems like a lifetime from now, but it'll be come quicker than we think, the generic gap will be 25%. In other words, the coinsurance will be, the Medicare will pay 75%, and the plan participant will only have to pay 25%. That's quite a jump from 7% in 2011, 14% in 2012, 2013, 21%, and next year it'll be 28%. So that's how that works. Again, if you have any questions on any of this stuff, just raise your hand or write me a note on the bottom of your thing, and we'll be able to cover that and at the tail end. All right, non-deductibility of retiree drug subsidy payments. This is kind of complicated stuff. Again, I realize that. I'm just trying my best to try to explain it. The Affordable Care Act for retirees now, we're no longer talking about actives. Everything we've been talking about up until this point I've been really assuming that we're dealing with active plan participants who are entitled to Medicare. So the Medicare secondary payer rules work. The plan is primary payer. Medicare is secondary payer. That's when you have an active employee. That's the Medicare secondary payer rules. When you deal with the retiree, if the retiree is eligible for retiree medical through you guys as the employer, the plan, the private sector plan, is primary and Medicare is secondary. Now, chances are most people listening, based on the data that I see, most people, and probably everybody that's on the call that is listening to me live, you probably don't have a retiree health care benefit because they've become so expensive and everybody's been getting rid of those things for a number of years. So chances are you do not have a retiree medical benefit. So when somebody retires, there is no drug subsidy as part of your health plan that would apply to retirees. So this may be a moot point for you. But if you do have a retiree medical plan, then this does apply. So let's just read this really quick, because again, we're just covering everything here. And I realize that this probably doesn't apply. But nevertheless, here's the rule, so you know it. The Affordable Care Act addresses and eliminates the double tax benefit associated with retiree drug subsidy payments for tax years beginning in 2013. So just a few months ago, January 1 is when this rule went into effect. Now, the Affordable Care Act amends the Internal Revenue Code to provide that an employer's tax deduction for allowable prescription drug expenses is reduced to the extent that the employer is reimbursed for such expenses through the retiree drug subsidy. So, if you have a plan and if you as an employer, as part of your plan, are receiving any kind of subsidy for retiree, not active, retiree drugs, you can no longer deduct that as a tax deduction as an employer. That's it. That's it. The rest of this stuff just kind of says more about that, but that's the rule. Now, that's what we've covered. We're not done here, but that's what we've covered and we did not were able to cover last time. So let me go into all the new material now. That is really the part that you signed up for. Okay. Let me set this up here. We all remember that back in June of 2012, the U.S. Supreme Court ruled that the individual mandate, which is the cornerstone of healthcare reform, if that fell apart, in other words, the requirement that we could make all Americans make them buy health insurance under the Commerce Clause of the Constitution, that was the question. And the U.S. Supreme Court ruled that actually, no, you could not require, did you hear me correctly? No, you could not require Americans to purchase health insurance. But what you could do is you could, Congress has the ability to create taxes. And so what the U.S. Supreme Court said, and it was very controversial because it was a Republican-dominated court, but the Supreme Chief Justice John Roberts spoke, and he in fact voted for this, and said that since Congress has the powers under the Constitution to create a tax, as long as you don't call it a penalty or a fine, the Affordable Care Act could go forward, and the individual mandate, meaning that all individuals must have health insurance. If they're not getting it through the employer, they got to go out and buy it themselves or get it through the exchanges that are going to be forthcoming, and we'll touch on that in a few minutes. If they don't, then they would be subject to a tax. So whenever you hear about, as we're going to go through this stuff now, there are 47 currently, 47 opportunities for the Internal Revenue Service to come in and say, you did this and you shouldn't have done this, Mr. or Mrs. Employer, or you didn't do this and you should have done it, you're not in compliance. There's 47 of those. Now there are 15,000, and you've probably heard this number on the news, the IRS is hiring 15,000 inspectors, 15,000 individuals. Their sole job is to go out and audit both the exchanges and the employers. Now there are 33 federal exchanges. I happen to live in Wisconsin. In Wisconsin, our governor decided that, forget it, we're not going to have a private exchange. We're not going to do that. And what that in fact meant, and there are 33 other states that fall into the same category, is that we'll get a federal exchange. The feds will come in and impose their own exchange on us. Now, that is really up for grabs, as we're going to discuss here in a little while. The rest of the country, the other 50 minus 33, so that would be, what, 20? No, that'd be 17. 17 states have either a private exchange or some other type of exchange, and we won't go into that part. Now, those 15,000 investigators will be able to investigate the federal exchanges. They have the power to do that, or the private exchanges, if you're in a state that has a private exchange or any variant of a private exchange. And these 47 taxes, some of those apply to the exchanges. Most of them apply to you as an employer. So this is something you're going to want to, this is going to be a gem that I'm going to give you here, because, I was able to find where actually somebody took the time to go through that 2,700 pages and literally find all of the areas that actually had a tax associated with it. But it's not called that in the law. And when you're reading the stuff in the paper or the trade magazines or the HR emails you get, all of that stuff, you talk about penalties. Well, just take the penalty out of it, because there are no penalties. They are taxes, according to the Supreme Court. All right, enough said. So that's what that is. Violation number 1. The Affordable Care Act prohibits group health plans from discriminating in favor of highly compensated individuals. Now, when originally written in 2010, the law said that all health plans, whether they be self-funded or whether they be insured, all health plans will have non-discrimination rules, and those non-discrimination rules, of which there are 3 under Section 105H of the Internal Revenue Code. Those will be applied to all plans, insured and self-funded. Now, historically, insured plans, the non-discrimination rules for insured plans were governed by Section 106 of the Code. Bear with me, friends. And self-funded non-discrimination rules were found in Section 105H of the Code. Section 106 historically applied to insured plans. There are 2 non-discrimination rules, 2. Section 105H has 3. The Affordable Care Act says we're doing away with the non-discrimination rules in Section 106, and so insured and self-funded plans are going to have not 2, but 3 non-discrimination rules, which have always existed in Section 105H of the Code. So in other words, there are no longer will be 2 ways that you can trip up. Now there are 3 ways you can trip up. There was enormous rebellion from employers and lobbyists and lots of people. So even though this is the violation that was in the original law and which you may have heard of, it was repealed. So as we speak, everything I've just got done telling you is what the law originally said, but we're back to the old rules again because there was just way too much heat put upon Health and Human Services, and they just said, well, we just can't fight this thing. We've got other things to fight. So if you have an insured health plan, you must comply with the 2 non-discrimination rules, which basically say that you cannot operate a plan in favor of highly compensated employees. And the Section 106 rules apply, and I'm not going to go through those rules in the interest of time because they will eat up a lot of time. But there's only 2. That's what you have to remember today, okay? You cannot operate a plan, an insured plan, that violates 2 non-discrimination rules according to 106 of the Code. If you have a self-funded plan, there are 3, and you cannot violate any one of the 3, otherwise the whole plan is disqualified. Disqualification means the plan is taxable then to plan participants. So that's not a good thing. So the whole point here is that violation number 1 originally under the law was going to move all non-discrimination rules to 105H. That was repealed until further notice, and we have no idea when that's going to be. So we're back to the old rules. Violation number 2. By the way, I'm not going to read all 47 of these. I'm going to only comment on some of the ones that I know would particularly pertain to you. But I'm just going to open them up for you, and you can download these things off of the system. Violation number 2, the Affordable Care Act establishes temporary reinsurance. Okay, reinsurance is stop-loss insurance, same thing. A reinsurance program to provide reimbursement for a portion of the cost of providing health insurance coverage to early retirees. Okay, this provision was a funded program, and that provision has been exhausted. Okay, so now we're down to basically 45 penalties. Because the first 2 here now have been pretty much gone by the wayside. Number 3, the Affordable Care Act imposes a penalty on health plans identified by Health and Human Services, a penalty fee report, which is to be collected by the Financial Management Service after notice by the Department of Treasury. Okay, that's a violation in the law. You probably haven't heard of that, and because it hasn't been codified in any regulations. We don't know what that means yet. We just know that that's going to be something coming down the pike. Right now, it doesn't exist. We just know that it's going to be there, but we don't know how to comply with it because there are no regulations. All right? But that is a violation that is going to be forthcoming. So it's sort of like, not that you want to keep that in mind, but that's what I'm asking you to do. Number 4, the ACA requires state exchanges to send to Treasury a list of the individuals exempt from having minimum essential coverage. Those eligible for premium assistance tax credit, which would be people that fall basically within 400% of the federal poverty level, and those who notified the exchange of a change in employer or who ceased coverage under a qualified health plan. What that all boils down to say, my friends, is that the government wants to know and have an accounting for exactly every single individual in the United States. It's a big number. Who has health insurance through their employer? Who has health insurance as a dependent through their parents? Or who has health insurance through an exchange? And if they're through an exchange, is there a premium assistance tax credit? So this is an accounting function. This is an accounting function. This is not something you have to worry about. The exchanges will have to worry about this part. Number 5, the Affordable Care Act has a provision providing a tax exemption for nonprofit health insurance companies receiving federal startup grants or loans. Okay, so this is simply saying that there are health insurance companies that are for-profit, and then there are certain health insurance companies that are non-profit. Now, the non-profits tend to be the smaller health insurance companies. They're not the big three, Humana, United Healthcare, or the Blues plans, the Blue Cross plans. Now, the Blue Cross plans is treated kind of separately as far as these taxes are concerned, and one of these is going to be coming up as a violation. You'll see here in a few minutes. So what this means is that there is a tax exemption which should translate into lower costs by a nonprofit health insurance company. That's good because there's something called the minimum loss ratio, the MLR rule, which is, depending if you're a small or large employer, 80% or 85% is the maximum loss ratio that the insurance company can incur. If they go over that, which means that they're overcharging you, then they have to give each individual, or in some circumstances, the employer, a rebate. You probably have heard about that, but that's kind of comes into play here. For nonprofit health insurance companies, they get a tax exemption, so their costs go down, so it's easier for them to meet the minimum loss ratio. That's the commentary on that rule. Number 6, the Affordable Care Act contains a provision providing a tax exemption for entities providing stop-loss insurance for individual policies during the first 3 years of state exchanges. So if you decide as an employer to get out of the healthcare business, or if you're offering a plan and one of your employees opts out, or a couple of employees opt out of your health plan and decide to go to a state exchange, if that state exchange and the policy that one of your employees or somebody who's unemployed and they go to the exchange because that's the only way they can get health insurance, if they buy a policy that has stop-loss insurance, there's a tax exemption for that for the first 3 years in the exchange. How does that affect you? It doesn't as an employer, but it's something that you should know about. The Affordable Care Act contains a provision providing premium assistance refundable tax credits for applicable taxpayers who purchase insurance through an exchange, paid directly to the insurance plans monthly or to individuals who pay out of pocket at the end of the taxable year. Again, this is something for the exchange. This one does not apply to you. Now you're thinking, oh, how long is this going to go on here, because I want to know what applies to me. Don't worry, they're coming. The Affordable Care Act contains a provision providing a cost-sharing subsidy for applicable taxpayers to reduce annual out-of-pocket deductibles. This one applies to you. Now, you cannot, beginning in 2014, as an employer. You cannot offer any plan where the monthly premium that the employee is responsible for, it cannot exceed 9.5% of that individual, that employee's annual household income. If you offer health insurance, that would be considered unaffordable. And if that's the case, what would happen is the government would step in and offer a subsidy, but you would incur a fine. You would incur a fine. You'd incur a tax for not offering affordable health care. Remember, this is called the Affordable Care Act. You would be fined if you're not providing essential health care benefits, that's an official term under the law, that cost more than 9.5% of an individual's annual income. The weird part about this is that most employers, believe it or not, are really not going to have a problem with this. But for those employers that offer whose compensation tends to be on the low end for a variety of reasons. That doesn't mean you're a bad employer. The economics dictate that you have a lot of people that, for example, are minimum wage workers. Suddenly you're going to have to take into account not just offering a plan, but given the compensation that we have for our employees, are any of those employees going to incur more than 9.5% of their monthly premium? It's only the monthly premium, my friends, we're talking about here. And if that exceeds 9.5% of their gross income for their household income, again, you could have two people. Most people are dual income families today. So what is the total income of the family? You're going to have to know that number. I don't know exactly how you're going to know that number. I haven't seen a rule on that, but that is the rule. So there is a violation. Number 8, you might want to asterisk this if you're printing out, if you've already printed out the PowerPoints. Or just write down, violation number 8 does apply to me. Number 9, the Affordable Care Act contains a provision outlining procedures for determining eligibility for the exchanges. We're not going to get into that. 10, the Affordable Care Act provides a provision allowing advanced determination of payment of premium tax credits and cost-sharing reductions. Okay, there's another rule here, and the other rule is that, you know, back in the good old days, when we offered health care plans as employers, or as an employee, we had a health care plan, which I guess is all of us. You'd have like 90-10 plans, 80-20 plans, 60-40 plans, meaning that in a 90-10 plan, the plan, that would have been a typical in-network PPO co-insurance differential back in the good old days. The plan would pay 90% for in-network benefits. The plan participant would be responsible for 10% up to an out-of-pocket maximum. We're all familiar with that. Well, as costs began to really escalate, particularly in the last decade, and particularly in the last few years, the Affordable Care Act, this is going to sound like a political comment, and I'm not making it as a political comment. I'm just trying to drive home a point. The existence of bureaucracy has driven costs up considerably. Healthcare costs are not a normal good. It is technology. It is the fact that as the median age of us as a society we're getting older every day. America will never be as younger in all of our lives as it is today. Okay, we are all getting older. And that's primarily because of the massive baby boom generation, 76 million people born between 1946 and 64. We're all starting to retire in that group. And so in the latter stages of life, healthcare gets more expensive, technology increases, costs for healthcare are going to go up. You add a huge level of bureaucracy on top of that, and it only exacerbates the cost problem. So you may be tempted to say, well, gee, I want to offer a plan that's a 60-40 plan. You can do that, but that's the lowest you can go. You cannot offer a plan that has a co-insurance differential of less than 60%. For example, you couldn't offer a 50-50 plan. We'll pay 50%, and the employee pays the other 50%. Can't do that. That is a violation of the law. 60-40 is the lowest you can go. You can be better than that, but not worse. If you go worse than that, the government offers premium tax credits and cost-sharing reductions to the employees, to your employees, but they're going to tax you for, in essence, what they're going to deem to be an unaffordable plan. And that's what violation 10 is. So make a little note. Violation 10 applies to me, and we've just explained it. Violation 11. The Affordable Care Act contains provision authoring the IRS to disclose certain taxpayer information to HHS. A little spooky there for purposes of determining eligibility for premium tax credit. The way this is going to work is that you have the Department of Labor, you have the Treasury, you have a sub-agency of the Treasury, which is the Internal Revenue Service. And then you have Health and Human Services. The hammer, the enforcer, is the Internal Revenue Service. De facto, the Internal Revenue Service is going to be the authority. Once the rules have all been made, and there will come a point where Health and Human Services will kind of fall back and fade back into backstage. Who's going to become upfront and personal is the Internal Revenue Service. The Internal Revenue Service is going to, in effect, be who runs healthcare at the national level. It's going to be who actually determines who gets health care, what the cost of health care is, what taxes will be levied, and as things change, and they always do in the law, it'll be the Internal Revenue Service. So anytime you see an IRS rule, take that as really important because, number one, it is the rule, but it's also subject to change. And the change probably is not going to be for the better. And the reason it won't be for the better is because of the enormous federal debt that we have. We simply don't have the opportunity as America today to offer goodies anymore. We don't have any money. So violation number 11 here, even though it's going to be offering these tax credits, this does apply to you as well. Now, you know that beginning last year, there was actually for calendar year 2012, in January of this year, 2013, there was a little spot on the W-2 that when you issued it out, it was actually box number 12. There were two boxes under number 12 on the W-2 form that you had to fill out that was the value of your health insurance to your employees. You had to do that. If you didn't do that, well, at this point, keep it quiet. But the law required you to do that, and I'm going to assume that most of you did. All of you did. That's what violation 11 is talking about here, is they're going to be gathering a lot more data on your employees, your health care, taxpayer information, and they're going to share that information, how much employees make, with Health and Human Services, so that all of these moving parts, how much the employee makes, what is the employer's health insurance, is it affordable, as we've already discussed, what premium tax credits need to be applied because the employer's plan is deemed unaffordable or not, or it is affordable and therefore no premium tax credits or cost-sharing subsidies are available. All of that's going to have to be fed, and the coordination of all of this is going to be something to be seen between the IRS and Health and Human Services. That is what violation 11 is talking about. Violation 12. By the way, I'm looking at the clock here. We're going to have to kind of cut some of these kind of short here. all violations, all taxes under the Affordable Care Act, operative term, all, anything that you have to pay the government, this is the first time to my knowledge in any law that applies to employment. None of these are tax deductible. So if you have to, in the past, if you got fined for whatever some reason under ERISA or HIPAA or whatever it might be, you could deduct that as an employer on your taxes. None of the taxes that you may have to pay if you mess up as an employer, none of them are tax deductible. Now, that's not what Violation 12 was about, but it kind of leads into that. And it has a provision that provides non-refundable tax credits for small employers, no more than 25 full-time equivalents. So full-time employees plus all part-time hours that add up to a 40-hour work week, with annual wages averaging no more than $50,000 for contributions made. In other words, there's a formula out there, and this was out there since 2010, that if you're a small employer with 25 or fewer full-time equivalents, you could get money from the federal government to subsidize what we all consider to be the high cost of private sector health care insurance. This has been around a while. It's still out there. It applies to you. Number 13, the ACA contains a provision requiring all U.S. citizens to maintain minimum essential coverage. Okay, that's the individual mandate, and if all U.S. citizens do not have, and legal residents, do not maintain minimum essential health insurance, which we've covered in past webinars, there will be a tax on the individual. So if somebody opts out as one of your employees, they opt out of the plan, you really owe it to tell them that, hey, listen, you better have health insurance, or otherwise you are going to be taxed if you opt out of our plan. That's fine. Glad to get you off the roll, but you better get it because otherwise you're going to be taxed. Okay, we are at 12:30, so let me just kind of go through a couple of these really quick here and see if there's any major ones. You know what? I'm going to stop here because you can download the rest of these. There are 47. You can read them. As you can see, they're fairly short. And take any questions that you may have at this point. So raise your hand if you have a question. Otherwise, I'm going to look down here on the messages here and see if we have any questions there. Bear with me, folks. I'm just reading through the lines here. Okay, nobody has raised their hand, and I can't see. Nobody has asked me any questions that are pertinent. It looks like some of you have been having trouble downloading the materials. So here's what I'd recommend you do. Bear with me, folks. 1 minute. Okay, here's an email address. If you had problems downloading the PowerPoints, what you can do is you can send just say, please send me the May 30th PowerPoint presentations, and you can send it. Please send it to support@yourfutureoffice.com. You have my email on there too, but that's really for if you have any individual questions that I can help you with. But so if you have any individual questions, then email me, craig.d@davidsonmarketing.com, and I'd be more than happy to answer that. It won't cost you anything. We just want to help you out. However, if you want the PowerPoint presentations, and if you had difficulty downloading them, which I'm not really sure why that would be the case, we never had that problem before, but nevertheless, we want to help you. If you need the PowerPoint presentations, support@yourfutureoffice.com. Got it? Support@yourfutureoffice.com. You don't have to write a big thing. Just write down, need the May 30th PowerPoints, and we will more than be happy to send them to you. I still don't see any questions, so I will be more than happy to send those to you. And please fill out the evaluations to let us know how we're doing. And we look forward to hosting you on future webinars. We will send them in the mail to you as they become available. Thanks a lot for your time, everybody. And we are over 1 hour, so if you do need any kind of credit through HRCI, you now do qualify for that for participating. Thank you very much, and have yourselves a great afternoon or a great morning, depending on where you're at. Have a good day. Goodbye.